Good morning, everyone. Today we are going to continue with our activities on the book club with the fundamentals of diagnostic radiology. Today we are going to talk about the chapter on the thoracic pulmonary arteries and peripheral vascular disorders. This presentation was originally prepared and presented by Dr. Tarakawa Hwezi, and for technical reasons it was not recorded properly, so I will present it again. First, we should know that the wall of the arteries and the veins, the walls are made of three layers. From inside out, they are the intima, the media, and the adventitia. The intima, it's a single cell layer, single cell thickness with the primary function of interacting with the flowing blood. So it acts to prevent thrombosis, and it is the most chemically active layer. And you can see here that this is a cross section through an artery showing the intima, the media, and the adventitia, and this is a histopathologic section showing the adventitia and the media, the adventitia and the exterior of the artery, the media, and the intima, which is a single cell layer. Here you can see it on a magnified view here as a single cell layer. The media is composed mostly of smooth muscles. It's greater in the large and muscular arteries and less in the smaller arteries and veins. Smooth muscle cells can contract to augment normal hemodynamic function and to respond to stress, such as with vasoconstriction. The adventitia, which is the outermost layer, it's a supportive connective tissue, can vary in thickness and surrounds and supports the media. So the anatomical structure of the vessel wall is actually simple, but there are multiple physiologic and pathologic functions. They are very complex, and most part is poorly understood. There are a wide variety of diseases can affect the vessel wall, especially the arterial wall. So these diseases includes inflammation like vasculitis, fibromuscular disease, connective tissue disease, trauma, and degeneration like in atherosclerosis. Radiographically, first we should have a proper angiographic suit, which most of the angiographic suits have two major types of equipments. These are the patient monitoring devices and the radiographic equipments. The patient monitoring devices are essential for patient's care during the procedure, especially in cases of conscious sedation. There are usually one or more channels for pressure measurements and vital signs monitoring equipments. The radiographic equipment is based on the C-arm design that allows complex angulation, and it's equipped for digital acquisition only. The tools that we use during angiographic procedures, there are a number of catheters in the interventional radiology, can be divided generally into five types of catheters. These are the diagnostic angiographic catheters, the microcatheters, drainage catheters, balloon catheters, and central venous catheters. So, what are the medications that we use during angiography? There are a number of medications used in the interventional suite for conscious sedations. They are most common. The two most common medications are fentanyl and midazolam. If one is to administer this medication, we should know how to reverse the effect of these medications. Fentanyl is reversed by naloxone, and midazolam is reversed with flumazenil. Antibiotic prophylaxis for vascular and interventional radiology is somewhat controversial. Intra-arterial pharmacoangiography consists mainly of either vasodilators or vasoconstrictors. The thrombolytic agents that are used actually lyse or dissolve the existing thrombus. Most commonly used are streptokinase, urokinase, alteplase, and retiplase. Regarding thoracic aortography, first we should know the anatomy of the thoracic aorta. The aorta extends from the aortic valve to the diaphragm, generally divided into three main sections: the ascending, the arch, and the descending aorta. The classic pattern of the great vessels, it's approximately present in 70% of the population. It consists of right brachiocephalic, left common carotid, and left subclavian artery. You can see here in this angiography, this is the diagnostic angiographic catheter seen with its tip in the ascending aorta, and you can see the arch of the artery, of the aorta. Sorry, you can see the classic pattern of branches. That is the brachiocephalic, which they divide into the common carotid and the right subclavian. You can see the left common carotid and the left subclavian, giving here the vertebral artery. So there are multiple variations in the origin of the great vessels from the aortic arch. The most frequent is a common origin of right brachiocephalic and left common carotid arteries. This variation is called bovine anatomy, which occurs in up to 20% individuals. And you can see here there is this is the common origin of the brachiocephalic and the common carotid, and this is the left common carotid, and this is the left subclavian artery, and you can see here an aortic bump. We will talk about it later. Other variations include aberrant right subclavian artery, left vertebral artery arising from the aortic arch. So you can see here again, this is the diagnostic catheter in the ascending aorta, and you can see here the right common carotid, the left common carotid, and you can see the brachiocephalic, and you can see here the left subclavian, and what's this branch in between? It is the left vertebral artery arising from the aortic arch, and you can see here an aortic bump. Another important variation is the presence of an angiographically identifiable ductus diverticulum, which is called ductus bump, which occurs in 90% of in 9% of adults. The ductus diverticulum appears as a fusiform dilatation along the ventromedial aspect of the proximal descending aorta adjacent to the ligamentum arteriosum. So, in addition to the great vessels, the thoracic aorta gives rise to the right and left coronary arteries, the intercostals, and the bronchial arteries. Some congenital anomalies of the aorta includes a number of anomalies. The most striking is the right-sided aortic arch with mirror image branching. Keep in mind that this right-sidedness with mirror image branching carries a 98% association with congenital heart disease, mostly tetralogy of Fallot. Two congenital anomalies are more often seen in an adult vascular radiology practice. These are the left-sided normal arch with an aberrant right subclavian artery and pseudocorrectation or aortic kink of the thoracic aorta. We will talk about them briefly. The left-sided aortic arch with aberrant right subclavian artery is the most common arch anomaly, being found in about 1% of individuals. Rarely can be symptomatic. So you can see here, this is the right common carotid. There is no brachiocephalic, just right common carotid. You can see here, this is the left common carotid. You can see here, this is the left subclavian, and the right subclavian is arising from here, distal to the left subclavian artery, and crossing to the right side. And you can see here a dilatation at the origin of the aberrant right subclavian, which is called the diverticulum of Commarel. The right subclavian artery usually arises in this anomaly arises as the fourth branch of the arch, and it crosses the mediastinum to reach the right arm. Either it crosses behind the esophagus, most commonly, sometimes it crosses between trachea and esophagus, and rarely crosses anterior to the trachea. A dilatation of the origin of anomalous vessel is termed as diverticulum of Commarel, as we saw previously. If it is large, it may cause significant posterior impression on the esophagus, resulting in dysphagia. The diagnosis can be confirmed with either CT or MRA, and which is rarely needed, but this anomaly may be encountered with when angiography is being performed for other reasons, for example, cerebral angiography. Regarding correctation of the aorta, it is primarily an anomaly of the media. There is eccentric narrowing of the aortic lumen with infolding of the aortic arch. 70% of these are associated with congenital cardiac anomalies, the most common being bicuspid aortic valve. You can see here, this is the ascending aorta, and at the arch, at the isthmus, there is a narrowing of the thoracic, of the aortic arches, which is the correctation. There is something called pseudocorrectation or aortic kink, which is basically a mild form of correctation. There is infolding occurs at the ligamentum arteriosum, similar to the localized form of correctation, and the patient is usually asymptomatic because there is no hemodynamically significant stenosis. Okay, hemodynamically significant stenosis is when the pressure gradient is more than 10 millimeter mercury. If it is less than 10 millimeter mercury, it is not significant. The ascending aorta is elongated with a high transverse arch and redundant descending portion distal to the kink. There is a similar incidence of associated bicuspid aortic valve. So you can see here again there is a correctation here. Regarding aortic trauma, blunt trauma, most common trauma to the thoracic aorta, and it is the most common trauma to the thoracic aorta is blunt trauma. Most often results of motor vehicle crashes and falls. Penetrating trauma, less common, angiographically identifiable to penetrating injury to any vessel. There rarely can be a combination of both. The mechanism of blunt trauma is traditionally described as a result of sudden deceleration, resulting in tearing of the aorta at the junction of its fixed and mobile portions. The proximal ascending aorta just beyond the left subclavian, this is called the aortic isthmus, and just above the level of the diaphragm. These are the junction between the mobile and fixed parts of the aorta. Another popular theory involves compression of the chest that crushes the vascular structures, while more recent data have proposed a combination of the two mechanisms. Aortic transection is a clinical emergency. Recent data indicates that improvement in the transport from the accident scene to the pre-hospital treatment and the pre-hospital treatment regimens, up to 50% of individuals with a traumatic rupture of aorta reaches the hospital alive. In addition, many of the subsequent in-hospital deaths are related to other serious concomitant injuries that are inevitably occur in such serious trauma. The aortography has been the gold standard for the diagnosis of the thoracic aortic injury, but now it's only when endovascular repair is planned. Okay, so usually use CT because at the time being because it is more readily available and less invasive and faster, and it's important in diagnosing the aortic injury in addition to other injuries that usually occur together. So this aortogram demonstrates this area, that is a non-convex area of the aortic isthmus. It was suspected to be an aortic laceration, but it was an aortic bump, so it was not traumatic injury. So the key to telling the difference, it's the ductus bump is very smooth, convex, without acute margins. An aortic tear usually has an acute margin, irregularly shaped, and may have other associated abnormalities like narrowing of the aorta, persistence of a contrast in the outpouching, double densities, and presence of intimal flap. These are the features that support the diagnosis of aortic injury. For example, you can see here this aortogram shows a normal variant of the aortic arch. This is the left vertebral artery arising from the arch, and you can see here this, which looks like an aortic bump, but it is an aortic laceration. You can see the rather acute angle. So the finding on CT of blunt aortic trauma falls in two main categories. There are indirect signs and direct signs. The indirect signs, which is mediastinal hemorrhage, poorly defined fat planes, prevascular hematoma, periaortic hematoma, while the direct signs include abnormal contour of the aorta, changing the caliber of the aorta, contrast extravasation, and intraluminal irregularity. You can see here there is hemorrhage, mediastinal hemorrhage, you can see here. In addition, there is an aortic laceration, clearly seen here. So by using this criteria, CT has been very valuable as a screening tool, sometimes reported as 100% sensitivity and 100% negative predictive values. When performing arch aortography, the great vessels and the diaphragm must be included because usually there are multiple concomitant injuries. So you can see here there is an injury to the great vessels in this 23-year-old male, which was a victim of motor vehicle accident. The aortogram shows normal arch, but there is no right subclavian. You cannot see any, just the common carotid. So on selective catheterization of the brachiocephalic trunk with contrast injection, there was an occlusion of the right subclavian with contrast passing to the distally through this collateral artery. Regarding aneurysms of the thoracic aorta, they are being classified according to what part of the aorta is involved. Is it ascending arch or descending thoracic aorta? The aneurysms in the ascending aorta include cystic medial necrosis, Marfan Syndrome, and syphilitic aneurysms, while of the arch, usually atherosclerotic, as well as those in the thoracic aortic aneurysms. Post-traumatic thoracic aortic aneurysms are most often occur at the prevalent site of injury. The aortic isthmus, while mycotic aneurysms occur more commonly associated with ascending, may occur anywhere along the course of the thoracic aorta. Aneurysms of the ascending aorta constitutes the majority of the thoracic aneurysms, up to 60%, followed by aneurysms of the descending aorta and much more rarely those of the arch and the thoraco-abdominal regions. A number of disease processes can lead to aneurysm formation of the thoracic aorta. For example, you can see here there is a large aneurysm in the ascending artery with dissection, this tiny flap. It was presumed to be from cystic medial necrosis. And you can see here also a large dilatation of the ascending aorta, representing an aneurysm with valvular regurgitation due to syphilis. You can see the contrast passing to the right atrium, which is normal, should not indicating a valve regurgitation. Cystic medial degeneration does occur in some patients with aging and appears to be accelerated by the presence of hypertension. In addition, the manifestations of the Marfan Syndrome and Ehlers-Danlos Syndrome results from cystic medial degeneration. Atherosclerotic disease infrequently causes aneurysms in the ascending aorta. However, aneurysms in the aortic arch are often atherosclerotic in etiology, and the most common cause of descending thoracic aortic aneurysms is certainly atherosclerotic disease. So atherosclerosis causes aneurysms in the descending thoracic aorta and aortic arch. Atherosclerosis of the thoracic aorta has the angiographic appearance of atherosclerosis elsewhere. So, there was luminal irregularity by plaques, with or without calcification, degeneration of the aortic wall, resulting in the thoracic aortic aneurysm formation. Atherosclerosis usually also causes stenosis or occlusion of the origin of the great vessels, particularly the left subclavian. Clinically, distal embolization is a feared complication, particularly stroke. So the thoracic aortic aneurysm can be diagnosed by non-invasive means including echo, MR, and CT. The CT is usually the largest role. Regarding the natural history of the thoracic aneurysms, the growth rate of the aneurysm greater for those of the descending aorta than those for the ascending aorta. So the descending aorta grows faster. The mean rate of rupture or dissection was 2% per year for aneurysms less than 5 cm in diameter, increasing to 3% per year for 5 to 5.9 centimeter aneurysms, suddenly increases to 7% per year if the aneurysm is more than 6 centimeter in diameter. Rupture and acute dissection of the are the major complications of the thoracic aortic aneurysms and can be fatal. Regarding vasculitis is defined as inflammatory process of the aorta and or great vessels. There are a relatively large number of vasculitides, but only tachyoso and arteritis and infection can occur frequently. Tachyoso arteritis have a striking angiographic pictures. It is a granulomatous or giant cell inflammation of the media and adventitia of the large elastic arteries. Mostly occurs in Asian women, more in female, 10 to 1. Most often affects the thoracic aorta and its proximal branches. The abdominal aorta also affected, the pulmonary arteries affected. There are two relatively distinct clinical phases of the disease. There is the early phase and the late phase. The early phase has a constitutional signs, symptoms, positive laboratory findings like increased ESR, positive C-reactive protein, while the radiographic findings of the early phase are usually negative, the angiographically negative. There is nothing. Some increase or thickness of the vessel wall on the CT and MRI, while angiography has a negative finding. While the late phase of the disease has marked thickening of the media and adventitia resulting in typical angiographic finding of smooth long segment stenosis, occlusion of the proximal great vessels, aneurysmal dilatation is uncommon but can occur. Angiographic involvement has been classified into 4 types depending on the site of involvement, including the great vessels, thoracic and abdominal aorta, as well as whether the disease is stenotic, which is the most cases, or with dilatations, rarely occurs. You can see here this is a case of tachyoso arteritis, giant cell arteritis. This is an angiogram of in case of tachyoso arteritis, showing this smooth and elongated narrowing of the major arteries here, and here. All of them are markedly thinned with smooth, long stenotic portions. Aortic infection is usually divided into 2 types based on the microorganism, either syphilitic or non-syphilitic, which is mycotic. So the syphilitic aortitis, it occurs approximately in 12% of patients with untreated syphilis. The classic radiographic finding is aneurysm formation of the ascending aorta, less commonly extend to the arch. Large aneurysms are not uncommon. Fine dystrophic calcification by chest radiography exclusively in the ascending aorta occurs in up to 40%. Aortic insufficiency is often present and there is a high likelihood of aneurysm rupture if untreated. Mycotic or non-syphilitic aortitis is much more common in the United States, and most common organism is Staphylococci, Streptococci, and Salmonella, although virtually any microorganism can be a causative factor for, especially in immunocompromised patients. Angiography demonstrates an irregular circular aneurysm of the ascending aorta, which can also involve the arch and the descending aorta, including the thoracoabdominal aorta. Any vessel can be involved, including the great vessels. Diagnosis based on patient's constitution consistent with an infection. There are two non-inflammatory connective tissue diseases like they are the Marfan Syndrome and Ehlers-Danlos Syndrome. So we will talk about them because they are radiologically significant. Marfan syndrome is an autosomal dominant disorder that affects approximately 1 per 10,000 individuals throughout the world, all genders, all races, all ethnic groups. Widespread effects including the eye, skeleton, heart, and aorta. More than 50% have a cardiovascular complication. What happens is that there is weakening of the aortic root, producing aortic ectasia and aortic insufficiency, making the patient prone to aortic dissection. Dissection or left ventricular failure causes death in 1/3 of patients by 32 years of age, and in 2/3 by 50 years if left untreated. The classic aortogram appearance is that of a very large aneurysmal aortic root with sinotubular ectasia, or what's called the tulip bulb appearance. So tulip bulb appearance is a very suggestive of Marfan syndrome. You can see here in this case of Marfan syndrome, there is a marked dilatation of the aortic root, the tulip bulb appearance. It looks like a tulip with its bulb, and there is a dissection here with the dissection flap extending here to the abdominal aorta, and you can see here the superior mesenteric artery arising from the true lumen, okay, and the left renal artery here also arising from the true lumen of the abdominal aorta. A little bit later image shows a calcification of the right renal artery, indicating that it's arising from the false lumen. Regarding Ehlers-Danlos syndrome, it is a group of heritable connective tissue disorders characterized by hyperextensible joint and tissue fragility, and geographically tend to involve the ascending aorta, resulting in aneurysms, which are prone to dissection and rupture. Regarding aortic dissection, aortic dissection is a laceration of the aortic intima and the inner layer of the media, resulting in a cleavage of the aortic media. The blood will penetrate the aortic wall via the primary entry site, dissects the medial layer for a variable distance both upstream and particularly downstream, causing a false lumen. The blood flow may occur in both true and false lumens, but either the true lumen and the false lumen can thrombose. Aortic rupture characteristically occurs at the site of the primary entry, and it's the most common cause of death, with early mortality as high as 1% per hour if left untreated. 3/4 of all cases have involvement of the ascending aortic arch or both at autopsy, less than 25% being beyond the arch, and 25 to 45% of dissection originates in the ascending aorta and reaches the abdominal aorta. The classification for aortic dissection has been mainly two basic classifications, and both are directed towards the need for surgical intervention. The first classification is the DBEC classification, which consists of three types. The type 1 starting in the proximal aorta and courses into the descending thoracic aorta, type 2 limited to the ascending aorta, and type 3 limited to the descending aorta. While the Stanford classification based on two types, type A involving the ascending aorta, type B not involving the ascending aorta. What are the etiologic factors associated with aortic dissection? Usually there are three causes: either cystic medial degeneration, hypertension, or atherosclerosis. Other etiologic factors include inflammatory disease like aortitis, blunt trauma, iatrogenic trauma, for example, in patients with catheterization, congenital anomalies, and inheritable disorders of elastic tissue like Marfan, Turner, and Lardallo syndrome, congenitally abnormal aortic valves like bicuspid aortic valve, also associated with aortic dissection. The main imaging modalities are four. This includes the echocardiography, CT, MRI, and catheter angiography, but CT has the most often employed imaging study. Angiography was long considered to be the diagnostic standard for evaluation of aortic dissection, but prospective study shows the diagnosis of aortic dissection, although the sensitivity of aortogram is 90%, it decreases to only 77% when the definition of the aortic dissection included intramural hematoma with non-communicating dissection. So if the dissection is non-communicating, the angiography has a decreased sensitivity for dissection. The complete diagnosis of aortic dissection requires visualization of both true and false lumen. This is CT of the thorax, shows evidence of dissection of the descending thoracic aorta. This is the true lumen and this is the false lumen. Okay, and the lateral angiogram shows filling of the true lumen, and it is compressed by the false lumen here. The classic angiographic findings is that of a double barrel aorta with interposed intimal flap. This is seen in about 87% of cases, and the most diagnostic modalities for aortic dissection are aimed at the actual proximal dissections, such as dissection requires emergency surgical intervention to prevent rupture into the pericardium. So, the more proximal, the more emergency the dissection is. In the differential diagnosis of the aortic dissection is intramural hematoma, penetrating aortic ulcer. So, aortic dissection, intramural hematoma, penetrating aortic ulcers, three diagnoses share much in common, and all of them, they are called acute aortic syndrome. The intramural hematoma, it's a localized hematoma within the aortic wall, usually occurs in the elderly, hypertensive patients, and may represent a controlled dissection. Not all agree on this, but it's thought to represent a localized dissection without identifiable entry or re-entry point. It may, however, certainly progress to dissection. Here, angiography plays little role. CT and MRI or ultrasound are the diagnostic tests of choice. Demonstrates characteristic intramural hematoma. Atherosclerotic plaques may ulcerate into the media, resulting in penetrating aortic ulcer. The presentation is usually an elderly hypertensive patient with marked atherosclerotic disease. The diagnosis is best made by CT, which demonstrates that the aortic ulcer is frequently associated with intramural hematoma. You can see here, this is an atherosclerotic aorta with a calcified plaque here, and there's an extravasation of contrast, including indicating hemorrhage extending into the wall of the descending aorta. The plaque may precipitate localized intramedial dissection associated with a variable amount of hematoma within the aortic wall. It may break through into the adventitia to form a pseudoaneurysm, or may rupture completely into the right or left hemithorax. The diagnosis is made at CT with the demonstration of a contrast material filled outpouching in the aorta. The absence of the dissection flap or false lumen is often in the presence of extensive aortic calcification. Although aortography once was the standard for diagnosis of many aortic diseases, it has largely been replaced by CT or MRI nowadays. Regarding pulmonary angiography, the pulmonary angiography performed from the femoral vein also can be performed from the internal jugular, brachial, or axillary veins. Special shaped pulmonary catheters, usually 5 to 7 French, multi-side hole pigtail designs with a near right angle curves, such as Grolman catheter, can be easily placed into the right or left pulmonary arteries. Traditionally, the pressure is obtained in the pulmonary artery as well as in the right atrium and in the right ventricle. Usually we use non-ionic low osmolar contrast material because there is less complications and there is a decrease in the cuff reflex. The anatomy of the pulmonary artery is variable, but for most part it follows the bronchi. Complications of the pulmonary angiography have mostly been reported for the diagnosis of pulmonary embolism, failed to increase in the presence of pulmonary artery hypertension, which is defined as pulmonary artery systolic pressure of more than 40 mm mercury, It has been reported that pulmonary angiography is contraindicated in patients with high pulmonary artery pressure or left bundle branch block because sometimes right bundle branch block occurs with the right hard-sided catheterization resulting in complete heart block. There may be a host of indications for pulmonary angiography in a particular patient. Such indications may include trauma, congenital anomalies, example, especially in congenital heart disease, tumor encasement of vessels, pulmonary hypertension, primary pulmonary hypertension, vasculitis, and stenosis. Two overriding indications are in the typical interventional radiology practice are PE and pulmonary arteriovenous malformation. So the most common indications are pulmonary embolism and pulmonary arteriovenous malformations, while all the other indications are rare to more or less degree. Pulmonary embolic disease can be divided into chronic and acute forms according to the history and the angiographic appearance. Pulmonary angiography for acute pulmonary embolism has been all but replaced with multi-slice CT, now often relegated to the difficult diagnostic situation. So nowadays we don't use pulmonary angiography to diagnose pulmonary embolism, we use CT scan. Maybe in some difficult or complex situations we might go to pulmonary angiography. For example, you can see here this is a CT of the chest with multiple bilateral filling defects in the pulmonary arteries consistent with pulmonary embolism. There are still some advantages of pulmonary angiography, although it's certainly less than perfect, but it's the gold standard. It allows visualization of the pelvic veins and the inferior vena cava, provides hemodynamic parameters like the right-sided heart pressure, the pulmonary artery pressure, as well as opportunity for therapy in the same setting, for example, filter or thrombolysis. Main disadvantage of pulmonary angiography is that it's invasive, which is not only uncomfortable for the patient, but has a number of complication rate, including arrhythmia, cardiac injury, for example, perforation, cardiac arrest, respiratory insufficiency, contrast reaction, excess hematoma, thrombosis, and even death. So the pulmonary arteriovenous malformation represent direct, while pulmonary arteriovenous malformation, it's a direct low pressure artery to vein connection. It's a fistula of the lung. They are associated with although they are associated with hereditary hemorrhagic telangiectasia, which is called Rondo-Osler-Weber syndrome, in 60 to 90% of reported cases, pulmonary arteriovenous malformations may occur spontaneously without hereditary hemorrhagic telangiectasia, or associated with other causes of trauma or erosion of a vessel by aneurysm, infection, or tumor. Pulmonary arteriovenous malformation can be diagnosed on the chest radiograph but are being diagnosed by CT, which will visualize even small AVMs. In addition, CT is an excellent method to screen patients and for follow-up post-embolotherapy. Pulmonary angiography is usually performed when one is contemplating transcatheter embolotherapy. For example, you can see here there is a pulmonary arteriovenous malformation with a feeding artery, a nidus here, a connection with a draining vein, and after a detachable plug placement here, injection shows obliteration of the connection.